the NELFT team, and I work as an extended scope practitioner within the NELFT physiotherapy department. And the topic I was asked to lead this afternoon was a quick assessment on shoulder within the primary care setting. So for some of you, this may be, you may be very well versed with this, but for some of you, it may be a revision, and for those it's new, please feel free to ask if you have any questions. The shoulder joint in itself, I've just started with a brief run of the anatomy of the shoulder joint. The shoulder joint, as you can see here, consists of articulation with the is made up of the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and some books also include the scapulothoracic articulation, the articulation between the scapula and the thoracic web ribs. So in terms of the articulations, as I told you, we will be looking primarily at the glenohumeral and acromioclavicular joint and look at the structures around it and where the pain could be emanating from. Assessment of the painful shoulder. Mitchell et al. And Artis et al. State that there are 4 most common causes of shoulder pain which are seen by the medical practitioners in primary care. And they classify it as the glenohumeral joint disorders, rotator cuff disorders, acromioclavicular joint disease, and pain which is referred from the neck. So history is very important while examining a patient with shoulder joint problems. History should include onset, characteristics of their pain, functional impact of shoulder pain, and within my practice, I tend to ask their dominant side, and questions including, do they have pain at rest or is it only on movement? Pain present at night. Nocturnal pain could indicate a few conditions where pain is present at night. Does the pain affect their sleeping position? Do they have pain anywhere else? In my assessment, I include one joint above and one joint below. So this may include neck assessment if I think the patient has pain emanating from the neck, and I also include the elbow. Also look at history to check if there's any acute trauma or any instability. Occupation and sporting activities. Certain occupations, patients from certain occupations may have repetitive strain causing pain in their shoulder. So this will highlight whether it could be occupation related, other joints affected, if there's any systemic symptoms or illness, or if they have any significant comorbidities. Now, when it comes to rotator cuff disorders, there are 4 conditions I've classified within rotator cuff disorders. One is cuff tendinopathy, one is impingement, one is subacromial bursitis, and the last one is rotator cuff tears. So looking at the glenohumeral joint, the most commonly seen conditions within the glenohumeral joint are adhesive capsulitis and osteoarthritis of the shoulder. When it comes to the acromioclavicular joint, you have traumatic dislocations, degenerative changes, and infections, although these are quite rare. This particular slide shows a flow chart. It's an adapted version taken from the Oxford Shoulder and Elbow Clinic. And this flow chart will help you diagnose a patient quickly as to where their symptoms are rising from and what it could indicate. This is quite an old slide, and this flowchart is a few years old, and there is a comprehensive one which is quite new, and I've included that in the slide. So this particular picture shows you what red flag symptoms could you expect and what you need to do with the referral. And if a patient has pain emanating from the neck, shoulder, how you can follow this flow chart to see what the problem could be. And based on what the problem is, you can then plan the treatment regime for your patient. So pain arising from elsewhere, this could be referred pain from the neck, myocardial infarction for left-sided shoulder pain, pain from the diaphragm area, and this could possibly include pain from the gallbladder, etc., if it is towards the mid-scapular region and towards the right side. Polymyalgia rheumatica, malignancy, specifically to those of apical lung cancers and metastasis with patients who have had previous cancers of the breast, etc. Now, red flag indicators, there again, it all, most of you who work in GP practices will probably have extensive access to patients' history. And this will be based on your history, symptoms, and signs of previous cancer, any unexplained deformity or mass swelling, a mass or a swelling to indicate a tumor. So the other red flag symptoms could be systemic infection, where there is any redness around the area. If the patient is unwell with fever, or if they are systemically unwell, all this would indicate any infection. The other red flag symptom would be patients who had trauma or an epileptic fit or who had an electric shock, and they are exhibiting signs of loss of rotation or movement in the shoulder, and you can visibly see a shape that is not normal, and this could indicate an unreduced dislocation of the shoulder. Now, following on from your subjective examination, the objective examination is very important. And in clinic here, we have the liberty of time. I'm sure that GPs and people who work in GP practice are pushed for time, and you have shorter duration for your assessments. But if time permits, it will be good for you to include examination of the neck, axilla, and chest wall, and also assess range of movements of the cervical spine, inspect the shoulder for any swelling, any muscle wasting, or any visible deformity, palpate the sternoclavicular joint, acromioclavicular joint, glenohumeral joint for tenderness, swelling, warmth, or crepitus, and compare for power, stability, and range. Range should include active, passive, and resisted if possible, and you should compare it with the good side. Now, looking at the examination of the shoulder, there are numerous tests which are elicited in various books. There are close to about 180 tests which you can rely on or use to conclude to a diagnosis of a potential shoulder problem. But some of the commonly included tests are illustrated in the next few slides. Always look for a painful arc. Painful arc, pain from 60 to 70 degrees all the way to 120 degrees on active abduction. Could indicate possible impingement. Test passive external rotators. If a patient has loss of external rotation passively, this could indicate OA, osteoarthritis of the glenohumeral joint, or adhesive capsulitis. A drop arm test is a quick test to indicate an acute rotator cuff tear. Unexplained significant sensory or motor deficit could indicate a neurological background to your patient's pain or symptoms. So now coming to rotator cuff disorders, again, cuff tendinopathy is very commonly seen in patients from 30 plus to about 75. Occupational history may reveal heavy lifting, repetitive movements, especially about shoulders. You could see it commonly in people who do a lot of painting work, lifting work, etc. Shelving, commonly seen in patients who do a lot of shelving work in your superstores. In these kind of patients, you will see that active and resisted movements are painful and may be partially restricted as well. And in cuff tendinopathy, passive movements are full and intact. They may be painful, And in some cases, patients do not have any pain on passive movements. They do exhibit a painful arc, and this is neither specific or sensitive as a clinical sign, but its presence of a positive painful arc indicates that the patient could have a potential rotator cuff disorder. Now, looking at the shoulder test, I've illustrated a few tests which we regularly do in clinic, and I've got a colleague here with me. So if you are all keen on seeing it, I'm able to demonstrate some of these tests, but we will try and do it as best as we can. And I will see how we can telecast this to you. So the first test I've illustrated, are you able to see me?
Yes,
the first test I've mentioned is the NAIRS test. The NAIRS test is a test which we use to diagnose the subacromial impingement. So what you tend to do is, with the patient in sitting, with one of your hands stabilizing the shoulder blade, or you depress and slightly depress the shoulder blade, you internally rotate the shoulder and then elevate the arm all the way up. Hajidas et al. States that there is a specificity of 60% and a sensitivity of 72% with this particular test. So this particular test indicates positive impingement. If the patient complains of pain anteriorly, this test would indicate subacromial impingement. If the patient is exhibiting or mentioning that the pain is in the posterior aspect of the shoulder, this test would indicate an internal impingement in the shoulder. So the second test we commonly do is what we call as a Hawkins-Kennedy test. Again, the author Hajidas et al. Indicates a sensitivity of 80% and a specificity of 56% for this test. With the patient in sitting, you elevate the arm to 90 degrees and then passively internally rotate the shoulder. A positive test provocates pain, and a negative, if there is no pain, then obviously the test is negative. The next test I have mentioned in this slide is horizontal adduction test. So the patient in sitting or standing, take the arm to 90 degrees and horizontally adduct the shoulder. So if the patient is complaining of pain while you perform this test indicates a pathology in the acromioclavicular joint. So what we are doing is we're actually closing the joint as we move. So if there is any pathology, and this pathology could include osteoarthritis or any other pathology following trauma to the acromioclavicular joint. So the painful arc test is the next test, and this is a very quick test which you can do to indicate any impingement. So all you do is ask the patient to actively abduct the arm. So if the patient is mentioning that they have pain anywhere between 60-70 degrees all the way to 120 degrees, that indicates an impingement, a positive impingement sign. So if the patient complains of pain again in the end range of either flexion or abduction, that again indicates a problem in the acromioclavicular joint. So in clinic, if you ask the patient to lift the arm and there's no pain, but they have pain all the way at the end, or abduct and they have pain all the way at the end, this could indicate a pathology in the acromioclavicular joint. The next test is the drop arm test. The drop arm test is used to diagnose a potential tear of the rotator cuff. So all we have to do is passively elevate the arm to 90 degrees and ask the patient to hold. In a patient who has complete cuff tear, they will not be able to hold and the arm will drop instantaneously, indicating they have a potential tear to the rotator cuff muscle. The next test is Yergason's test, and this is basically a test which is used to indicate a pathology in your biceps muscle or in the biceps tendon or in the within the joint, indicating slap lesions. So again, Hajidas et al. Indicates that this test is very low in sensitivity, only 32, and a specificity of 88%. So all we tend to do is flex the arm to 90 degrees. Can you please stand so they can? Okay, so flex the arm to 90 degrees with the forearm in pronation, with the elbow tucked towards the body. You ask the patient to supinate against your resistance. So can you supinate? And as the patient is supinating, you resist it and also feel for the biceps tendon in the bicipital groove. If there is any flicking or any movements felt within the groove, that indicates that there is a pathology there. Or if the patient is complaining of pain, that indicates a biceps tendon pathology. And if there is movement, that indicates that there's potentially a tear of the transverse humeral ligament. If you feel a pop, that could indicate, again, a possible slap lesion as well. So that's your Yergason's test. Speeds test again. Maybe we can stand for this. It's a simple test. All we do is ask the patient with the arm in supination, ask them to elevate the arm, and as they elevate, you apply resistance. And if the patient has pain reproduced in the anterior shoulder, that indicates a biceps tendon pathology. The next test I've documented down is a lift-off test. For the lift-off test, you ask the patient to bring their arm behind their back and ask them to lift their hand off their back. If they are unable to do it, or if there is weakness, you always compare it with the other side. If there is a lot of weakness, that could indicate a problem in the subscapularis muscle. There is the subscapularis muscle, again, is a part of the rotator cuff, which includes the supraspinatus, infraspinatus, teres minor, and the subscapularis. We will not be able to demonstrate the crank test because that needs the colleague to lie down, and we do not. I will not be able to move the computer there. So this is a chart from a paper presented by Callis et al. And this particular picture gives you how sensitive these tests are and how specific and reliable they are and what the positive value for these tests are. And a later study, as I mentioned, by Hajitas et al. Was done in 2012, and some of these findings correlate with the findings of Callis et al. In terms of a rotator cuff tear, there is a very strong indication that most of these tears, especially in the young, is following a trauma. And rotator cuff tears are also seen in the elderly, and these are mostly degenerative in nature and are atraumatic in origin. It's extremely difficult to differentiate partial tears from rotator cuff tendinopathy in clinical examination. And as I mentioned to you earlier, a positive drop arm test is helpful in detecting large or complete tears of the rotator cuff muscle. So with regards to the rotator cuff muscle tear, Stevenson and Trojan in 2002 have very clearly come up with this flow chart. And in their study and in their flow chart, they indicate that the likelihood of a rotator cuff tear, a complete tear, is greater than 95% with a positive drop arm test. So this particular flowchart will be extremely useful for you as well, along with the other flowchart which I mentioned earlier on in my presentation. So coming on to the glenohumeral joint disorders, I did mention that there are two conditions we commonly see within the glenohumeral joint. One is the adhesive capsulitis, most commonly seen in anybody over 35 to 40, going all the way to 65. And osteoarthritis of the glenohumeral joint, seen mostly in patients from over 60 onwards, or possibly from late 50s. These patients with pain in the glenohumeral joint usually indicate that they have a deep joint pain, and they definitely have restricted external rotation. And this is both actively and passively. The movements are restricted. The only way to differentiate between an adhesive capsulitis and glenohumeral joint osteoarthritis in the elderly would be with the help of image, possible X-ray of the joint. Adhesive capsulitis are more commonly seen in patients with diabetes It can also be seen after prolonged immobilization or following trauma. So history is very important when it comes to diagnosing some of these conditions. So again, with coming on to the acromioclavicular joint dysfunction, it's, as I mentioned earlier, it's secondary to trauma or due to osteoarthritis. Joint dislocation can occur after any injury and commonly seen from teenage up to 30 years. The most common symptoms exhibited are pain, tenderness, occasional swelling, and some patients do mention that they feel a bit of a click. So if the ligaments around the acromioclavicular joint have given way and if they have their symptoms of pain, some patients do have a clicking feeling within the joint on movements. And the best way to find out on clinical examination would be is a positive horizontal adduction and scarf test. Again, scarf test is with the elbow bent as against horizontal adduction with the arm with the elbow in extension. And they do complain of pain in the end range of flexion, abduction, and adduction. And in terms of osteoarthritis of the acromioclavicular joint, this can also lead to impingement. There again, an X-ray would help in revealing this. And in some cases, depending on the type of the acromion, if they have a sloping up acromion, that can, along with osteoarthritis, this can also lead to impingement. And these are patients who may not effectively improve with steroid injections or physiotherapy and may need to undergo subacromial decompression. Now, referred mechanical neck pain. There are a lot of patients we see in clinic who have pain in the shoulder and arm. They indicate that their pain is here. So pain in the upper arm could be as a result of either a rotator cuff pathology or a glenohumeral joint pathology, or it could be referred from the neck as well. So they have patients also report of pain in this aspect where they have pain in the middle and upper fibers of trapezius, and also report of pain in the lower neck and suprascapular area. And pain, as I said, is referred into the shoulder and upper arm. And this may also involve upper limb paresthesia. Some patients would also indicate that they have pins and needles or numbness. And a quick way to test it would be is to check for the movements of the cervical spine and shoulder, and they may reproduce generalized neck, upper back, or shoulder pain. Now, in terms of investigations, there are various investigations we can look at. X-ray, ultrasound, and MRI are the most commonly used investigations for shoulder pathology. So this was a good slide which I picked up from Andrew Cuff, and this is quite a new one. And in terms of when I would X-ray a shoulder, do I X-ray all frozen shoulders routinely? No. When do I X-ray first line? If a patient is atypically young, have a smoking history, or they've been on long-term steroid use, or even patients who've been on long-term anabolic steroid for those who exercise. We saw a patient in clinic not too long ago, 35-year-old gentleman who's been on anabolic steroids for bodybuilding, and he had a completely worn out glenohumeral joint. Patients with shoulder pain following trauma, X-ray would be a good choice. Patient with malignant history, again, X-ray would be a good choice. Would I always X-ray somebody before sending them to secondary care? Yes. In clinic here, sometimes we see patients who had X-ray a few years ago, but no recent X-ray. But if we are going to refer them to secondary care, we always request a recent X-ray. And would I X-ray somebody before I offer them steroid injection? Not always. Sometimes, yes, depending on the history and their presentation. And if there is an indication for X-ray, we do request if the GPs or the first contact practitioners haven't requested one. But in most cases, I should say that in the Havering area, we do get patients who've had most of the investigations prior to them being seen in our clinics. Now, in terms of investigations, Salek et al. State that 100% of patients were found normal in plain X-ray following shoulder pain. They haven't classified what kind of patients, because I'm sure if they've had patients with glenohumeral joint arthritis, that wouldn't be 100%. So I would probably take that with a pinch of salt there, because sometimes when you refer a patient with pain in the shoulder for an X-ray, that does bring up degenerative changes within the acromioclavicular joint and glenohumeral joint. But if it is following suspicion of following rotator cuff pathology, the X-ray will definitely be a normal X-ray. So imaging modalities such as MRI and ultrasound scan are accurate to detect soft tissue pathology such as rotator cuff tears, bursitis, or tendinopathies. In the outpatient setting, ultrasound for the shoulder is widely used because it can be done with dynamic scanning, and imaging can be done with ultrasound. And the appointment to get an ultrasound scan is probably quicker, it's cheaper, but the only downside to an ultrasound image is it's user sensitive. And again, Salek et al. In their study have demonstrated the specificity and sensitivity of ultrasound scan in shoulder imaging. Now, in terms of the MRI investigation, this may be more appropriate for patients following trauma, as this will help us to pick out any occult fractures or complete tears. This will also help us to choose the pathway required for the patient, so we can access access to orthopedics if they need to undergo any surgery or any management from orthopedics. I would also probably consider using MRI as an imaging modality for patients with chronic instability, especially the younger patients, and this is primarily to rule out a Bankart lesion. And in terms of instability in the older patients who are over probably 40, 45 plus, this will also help to rule out rotator cuff tears and labral tears. So I think I've come to the end of my presentation. So I'm sure there are a lot more we could have considered, but considering that I was only asked to do a presentation on assessing a shoulder in primary care, I would like to finish here.
Thank you so much, Parveen, for
yeah. And I think my colleague Murray is also going to come and have a brief chat about pathways of referral. I think she's going to come and have a brief chat as well.
While we wait for Murray, does anybody have a question for Parveen? If you have any questions, just put it in the chat box and we can go through them together. Any questions? Please feel free to ask any questions you've got. Probably someone has asked a question, any tips of shoulder pain management?
Well, in terms of management, I always tell patients there are three options for any pain management. One is to, depending on the diagnosis, is to try simple anti-inflammatories and pain medication. And then if that is not working, maybe try a course of physiotherapy. And if that is not working, then injections, with the last option being surgery. So it all depends on your examination as to where you think the patient fits in. Then we can choose the appropriate pathway for treatment. But here at NELFT, we do offer patients physiotherapy for shoulder, as well as we have ESPs who do offer steroid injections.
Okay. Someone has asked, can you talk about calcific tendinitis?
Calcific tendinitis, yes. Calcific tendinitis is a condition where you see calcification within, most commonly seen in the supraspinatus tendon, and patients have severe pain and it's a sudden onset as well, and nobody knows what causes this calcific tendinitis, but we were just having a recent presentation by one of the orthopedic surgeons who advised that there are different ways in which this can be treated. And if you look at the acute calcific tendinitis, there is some element of pain, but it does respond to steroid injections. But in cases where there are chronic calcific tendinitis, patient may need to undergo surgery. So this is diagnosed primarily with an X-ray, which definitely shows a tendon which is calcified. And in terms of treatment, if there are GPs who inject, they can try a steroid injection to help with symptom relief. And following that, if the symptoms are not improving, then they might have to refer this patient to orthopedics for either a barbotage, or probably if the barbotage is not successful, they might have to refer for keyhole surgery to clear the debris within the tendon.
Thank you for that. There's another question. Someone has asked, what does pain at night indicate?
Pain at night indicates nocturnal pain is very commonly seen in patients, as I said, in calcific tendinitis, and also in glenohumeral joint pathologies and rotator cuff pathologies. So if there is any unremitting night pain, I would probably clear any sinister pathology or any cancer symptoms. But having cleared that, if there is nocturnal pain, it could be any of these three. And so I have to examine the patient to rule out a glenohumeral joint or a rotator cuff pathology, which probably, based on examination and imaging, will give me a clearer picture as to what it could be.
Thank you. Someone has also asked, are there any exercises we can recommend to patients?
Yes, there are. It all depends on the findings of the examination, because if a patient has a rotator cuff tear, be it partial or be it a full thickness tear, we need to give the right kind of exercises. It has to be tailor-made to the patients, because imagine the joint sitting like this, and if one of the muscle is torn, then the stability within the joint is disturbed. And the exercises have to be tailor-made depending on which muscle is affected. Although I think a lot of times you get generalized strengthening exercises to strengthen the shoulder, it'll be good if the physio can isolate the muscle which is required to strengthen and then strengthen it. So here within our department, that is what we do. We try to find out which is the structure which is causing the problem and try and isolate it and treat it. So I will not be able to say a particular exercise, but we do have leaflets which we can help you out with by emailing them to you for you to use it for your patients. So if there is any patients who have stiffness within the shoulder, we have mobilizing exercises. And as I said, any exercise to strengthen has to be tailor-made for a particular patient.
Praveen, I hope you don't mind me butting in. My name is Sam Sotheby. I'm clinical lead here at Nell for Physio. There's for self-help and initial exercise, the CSP I've popped in the chat has got a fantastic website full of self-help resources, including exercises that people can try at home in the first instance while they're waiting for physiotherapy. I'm sure your SCPs will be using sort of resources similar to this already.
So someone has asked a question, not clinical questions, says, but what is the wait for a patient to be seen by the BHR MSK team, referring from primary care?
I think this is probably a question for me as well, Praveen, if you don't mind me jumping in.
Switch off.
Okay, so yeah, we do have very long waits at the moment. So while a lot of patients do get seen an awful lot sooner, The longest waits for our non-urgent care are very long. We're around a year for Barking, Dagenham and Havering. I think it's currently sitting, I'm sure Marie will be able to correct me if I'm wrong when she joins, around 12 weeks for Redbridge. As I say, we are making great strides in that at the moment to get back to our pre-COVID levels of weights. And now we have much better staffing, and we're having a big push on waiting list initiatives. We're also working very closely with the CCG around looking at the longer term, because as I'm sure most of you are aware, these weights are not all just due to COVID. They have been there for a while. So we're working on those with the CCG at the moment.
Thank you so
But
much.
the waits are shorter for the assessment service, right, Sam?
So yeah, so that's for routine physiotherapy. So in terms of the SMAS and MCATs in Havering and Barking and Dagenham, and there is an ESP service now in Redbridge as well, the waits are much shorter. So if someone does need to see an ESP physiotherapist, I mean, it's around 3 weeks or so at the moment. So it is a much quicker journey that way round.
Thank you so much for answering the questions.